Good morning, everyone. So we shall be starting the poster podium presentations involving cornea posters. So the first speaker is Dr. Prafulla Kumar Maharana. I request Dr. Maharana to please come to the dais. His poster is on molecular biology approach to study candidate gene mutations in keratoconus in Indian subjects.
Good morning, respected judges and the delegates. So I'll be
Please,
present.
yeah, please wait for slides to come. Please wait here.
So I'll be presenting my work on a molecular biology approach to study the role of candidate gene mutations in keratoconus in Indian subjects. So the background of this study was that keratoconus is a multifactorial cause. As you can see in this chart, patients who are genetically predisposed, once they are exposed to environmental factors like pollens, allergy, conjunctivitis, or systemic diseases like connective tissue disorders like Down syndrome, or iatrogenic causes like refractive surgery, they develop keratoconus. So the natural history of keratoconus give you few checkpoints. The first one is the onset, which is around puberty. Then there is a growth phase of rapid, followed by slow, and then a plateau, and finally it settles down beyond 40. So we have treatment for advanced diseases in the form of keratoplasty and progression. We have CXL, but we don't have something to halt or to check the development of keratoconus per se. So what we need to do is we have to find out which are the gene that puts a patient at risk, so that you can identify and you can build some treatment for that, and you can completely prevent the onset of keratoconus. So we did a literature review that these many genes were there in large population based studies, not case series involving keratoconus, but these are studies including large population based, where they did whole exome sequencing, and these are the genes that have been implicated. So out of this, because of financial constraint, you cannot do for, the exomic sequencing for each of these genes. So we finalized these 5 genes to be explored. Why? Because these are the most commonly described mutations involving these genes that can affect or onset of progression as well as progression of keratoconus. So as you can see, these are the cohort: Chinese, Caucasian, Chinese Australian, New Zealand population, and Latinos is the Caucasian population. These were the 5 genes: FNDC3B, MPTG, NF1B, ZNF469, and COL5 alpha 1. So these are the genes we choose to explore whether they have any role in Indian patients. But the other objective, which was most important to our study, is to explore if whole exome sequencing is possible in corneal stroma. So these are the 2 objectives of my study. We did this at RP Center, AIMS, New Delhi. Sample size was 15 because whole exome sequencing is a costly procedure, and AIMS New Delhi gave us a grant of 10 lakhs only. So for that, we selected 15 cases and 6 as control. We included all cases of idiopathic keratoconus, and since it involved genetic analysis, those patients who didn't consent, we excluded them. So these were the ethics committee approval as well as intermediate grant from AIMS New Delhi. So the basic method was that take human cornea, any patient undergoing keratoplasty, be it DLK or PPP, take the corneal stroma, extract the DNA and RNA from that, and then do a whole exome sequencing, and then run that through the Illumina software to know if these mutations are pathogenic. So these were the 15 patients that we took, and 3 of them had undergone PKP and 12 of them underwent DLK. This is the workflow for genetic analysis, which is still I'm trying to understand. All this job is done at by Department of Biochemistry, AIIMS New Delhi. So this is important because after all this analysis, we created patient's profile that contain all the short nucleotide pleomorphisms, and then we compared that with established normal population genomics, and then we filtered out which are the nucleotide or which are the mutations that are unique to Indian population, and then we run through them through the ANOVAR. What ANOVAR does is it searches all the existing database as well as literature, and then it gives you a classification. This mutation can be pathogenic, or it may be likely pathogenic, or it may be of uncertain significance, or it may be benign, or it has no role. So these many variants we identified in our population. 1200 for col 5 alpha 1, 750 for FNDC3B, 150 for MPTZ, and 75 for NF1B, and 450 for ZNF469. So out of this, col 5 alpha 1 has 4 unique mutation, and one mutation which was labeled as likely pathogenic. For rest of the genes, we had unique mutations, but all of them were of uncertain significance. So this brings to the conclusion of our study, which is, although the sample size was less, so it cannot be that hard evidence, but col5 alpha 1 mutation may have some role in onset of keratoconus in Indian subjects. The rest of the four genes, they have some unique mutations in Indian eyes. What is their exact role is not known. So limitation, as I said, it was a very small sample. So based on that, based on the result of the study, we requested Indian Council of Medical Research to give us a bigger grant. So finally, they have allocated almost 15 million for us to go for a larger study, taking a more number of patients and come out with some substantial evidence in future if everything goes right. With this, I'll conclude here. Thank you very much for your attention.
Thank you, Dr. Prafulla Kumar. I just have a question. How would you translate this into your clinical practice?
So, as I said, first you have to know which are the genes involved in the onset of keratoconus, and this is just the beginning of any research. Once that is done, the next step would be we would like to explore if it is possible during, like, in at AIMS, or in fact most of the major hospital, you have this test during pregnancy. You take the amniotic fluid, or you take the or you take the sample from the placenta and check for all these mutations we have known about, Downs, all this screening. So the second step would be to devise something, if it is possible, to identify these mutations in those samples. If that is feasible, then first is parents counseling. Second, the keratoconus onset is at around puberty, and there are definitive risk factors like eye rubbing, all this thing. So those patients will be counseled to avoid all these high risk activities starting from a very starting from an early age. So that may prevent the onset, and we will be also exploring new treatment modalities. If there are any, nowadays, all these genetic interventions are going on, is there any intervention that can correct these mutations? So those are all future plannings, but currently we are just exploring, is there any particular mutation that can give us, yes, these patients are at high risk of developing keratoconus.
Was any pedigree analysis done for your subjects? Any
Pardon?
history of keratoconus in the family?
No. Unfortunately, our goal was to take at least 5 familial keratoconus, but all of our cases were idiopathic only, and we deliberately excluded those cases which have some other association like Downs or the other diseases, because that would have diluted the data. So we took only idiopathic cases of keratoconus without any predisposing risk factors.
Thank you.
Thank you.
Can we now have the next presenter, Dr. Jitendra Jinagal? He's going to talk about the tough journey of Stevens-Johnson syndrome patients made easy.
Good morning, respected judges and the delegates. I will be speaking on basically the patients who had episode of Stevens-Johnson syndrome in the past, and they have presented to us in the chronic phase of their disease. So I have given the title, The Tough Journey of Stevens-Johnson Syndrome, Patients Made Easy. So as we know, Stevens-Johnson syndrome is a life-threatening hypersensitive mucocutaneous reaction which lead to vesicular bullous lesion in the skin and the mucosa. Similarly, it affects the eye in the acute phase also. But as the acute phase passes, if it is not treated with the help of some medical and surgical intervention in the form of amniotic membrane, these acute phase, if not treated properly, can lead to formation of chronic complications. So in acute phase, we can see there is the lid epidermal necrosis, there are conjunctival, acute conjunctival chemosis, as well as conjunctival epithelial defects, as well as corneal epithelial defects. So if these are not tackled properly, this may lead to formation of semblyfrons and other problems like stem cell deficiency and severe dry eye. So mainly, if once acute phase is resolved, these chronic surface inflammation lead to lid margin keratinization and other lid margin changes, which lead to cumulated blink related trauma to the ocular surface in the form of these manifestations they present in the chronic phase. So these are our patients who has lid margin keratinization, trichiasis, posterior migration of mucocorneal junction, symbilifrons, uh, atrophied meibomian glands, non-functioning meibomian glands, tarsal conjunctival keratinization, limbal stem cell deficiency, which may lead to chronic corneal epithelial defects, which may get infect and lead to ulceration and may lead to terminal end stage blindness. So we just went through our patients in the last 4 years who we included 34 eyes of the 17 patients who had these kind of findings. So we made the diagnosis of SJS sequel with the help of this scoring system described by Dr. Swapna Sanbag et al. So this scoring system says that if the score comes more than 5, so we can rule out other common differential diagnoses like OCP, drug-induced cicatrizing conjunctivitis, and chemical injuries. So by following this scoring system, we made the diagnosis of SJS sequel in our patients. So this is one of the representative cases in which we had lid margin changes which were causing corneal diseases like the patient, you can see the SPKs and active ulcer in the left side of the photographs. In the right side of the photograph shows the outcome of the patient after lid margin mucous membrane graft as well as after scleral contact lenses. The patient improved from 6/60 to 6/6 in both eyes. So by doing this intervention in chronic phase, at least we can rehabilitate the patient in the form of relief of symptoms as well as giving good visual outcomes. So total 34 AIOC 17 patients were taken care of, and the mean age was 29.5 years, and 11 out of total 17 patients needed mucous membrane grafting for lid margin disease, and scleral contact lens was applied in 13 of the 17 patients. So just coming to the discussion part of this paper, I want to highlight that cicatrizing conjunctivitis score is a handy tool to differentiate other differential diagnosis of this disease, and intervention focus on chronic stage in the form of mucous membrane graft and scleral contact lens. They give better outcome as compared to the pros alone or mucous membrane graft alone. So we suggest that early lid margin intervention and contact lens changes, if contact lens should be used if we note lid margin changes. So to conclude, SJS patient require routine and long-term follow-up. Any sign of lid-related keratopathy warrants definitive treatment, and excellent outcomes can be achieved in these devastating eyes with meticulous medical, surgical, and scleral contact lens use. Thank you.
Nice study. What was your aim of doing this study? Just to see the chronic, sequelae of SJS, or you wanted to see the outcome of mucous membrane graft or other interventions in these patients?
Basically, it was a medical record analysis just to see whether the patient get benefit after mucous membrane grafting as well as contact lens use in as compared to the no intervention done at all.
So do you find anything novel in this case series? Because mucous membrane grafts and PROS and scleral contact lenses, these all are proven for, these are the modalities to, manage these cases.
Yeah, this.
So did you find something new out of it?
Basically, only few studies are available. Just 2 groups are working on it. We just analyze our data also, and we could find the same findings that these intervention really help in benefiting the patient as compared to the conservative management as being done till recent times.
So better to operate when it's necessary rather than just leaving the patient on drops.
Yes.
Right.
Thank you.
Next, can we have Dr. Ipsita Muni with her presentation?
Good morning to all. My presentation is titled Keratic Precipitates, an Overlooked Sign of Microsporial Stromal Keratitis. So to introduce my topic, microsporia are unicellular eukaryotic organisms which have been reclassified as fungi. In the eye, they may cause keratoconjunctivitis, stromal keratitis, or endophthalmitis. Stromal keratitis is generally described as multifocal, coarse, anterior to deep stromal infiltrates. Due to lack of distinctive clinical features, it is commonly misdiagnosed as viral or fungal keratitis. In addition, it does not grow in commonly used microbiological media, and it requires a high degree of suspicion to be recognized, to be diagnosed in corneal smears. So in a retrospective study by Sambaparin et al., they found that most of the cases referred to their institutes had no clinical diagnosis and were being treated empirically, while a large proportion of the cases were being treated as HSV stromal keratitis or fungal keratitis. So in order to look for distinctive clinical features, we conducted a retrospective observational study between 2016 to 2022 at LV Prasad Eye Institute, Bhubaneswar. The inclusion criteria was histopathological or microbiological diagnosis of microsporidial stromal keratitis, and the exclusion criteria was a coexistent infection. So a total of 18 cases were found in which careful review of slit lamp photos revealed keratic precipitates distributed beyond the area of stromal keratitis. So this is just an overview of the cases that we found. 2 of the cases had a history of trauma, one with a pebble stone and one with caterpillar hair. The duration of symptoms ranged from 12 days to 5 months. 4 of the cases had a history of previous treatment. 3 were being treated empirically and 1 was being treated as viral dendritic keratitis. In our institute, the diagnosis of microsporidia was made with with scraping of corneal ulcer in 2 cases, and by histopathology in the remaining 3 cases. Most cases, therapeutic PK was done, and most cases were unsuccessful due to various causes, whereas 1 had a clear graft and 1 was managed medically. So these are some of the slit lamp photos showing the distribution of keratic precipitates beyond the area of the lesion. So just to provide a summary of 1 case, this was a case which was initially suspected as viral dendritic keratitis and was receiving treatment for the same. After a duration of 1 month, a central stromal infiltrate was found with stromal edema and pigmented keratic precipitates away from the lesion. So based on this clinical feature, we suspected microsporial keratitis, and a corneal biopsy was done in which microsporial spores were found. Due to worsening of the condition, therapeutic PK was done, followed by cataract surgery, followed by final visual acuity of 20 by 160. And in histopathology, microsporial stromal keratitis was found. So just to reiterate, microsporial stromal keratitis is generally described as either anterior to deep stromal infiltrate with surrounding stromal edema and exoedesis, or focal or full thickness monofocal infiltrate with overlying epithelial defects. Keratic precipitates are clusters of various inflammatory cells which are deposited onto the corneal endothelium from the aqueous humor. Keratic precipitates can be described on the basis of morphology, either with a slit lamp or in vivo confocal microscopy based on their size, color, and distribution. So features of keratic precipitates that suggest an infective cause are the presence of pigmentation if they extend beyond the midline, if they are clustered centrally or paracentrally with sparing of the inferior cornea, and in vivo confocal microscopy if they have a dendritiform or infiltrative morphology. So in our cases, we found that most of the cases were small, pigmented, and were distributed beyond the area of stromal keratitis, beyond the midline. So this contrasts with the typical feature of herpetic disciform stromal keratitis, where keratic precipitates are situated within the and presence of this distinctive feature tailor management accordingly. Thank you.
Nice presentation, Dr. Ipsita. Would you give importance to the presence of keratic precipitates in such cases in the absence of a microbiological histopathological diagnosis? Will just the presence of KPs with the clinical picture help you aid in making a diagnosis of microsporidia without microbiology?
If the case is not improving with the present therapy that we are giving, then we can give treatment for microsporial stromal keratitis in the absence of histopathological microbiological diagnosis.
And my question was, do you notice, you have just described 5 cases, did you notice them at the time of, time of presentation, or do these come later in the course of the disease? Because many times these are very protracted also. At what point in the treatment course did you notice these KPs? Did you
At
notice
the
them at the time
time,
of first presentation?
they were generally being treated as other cases. Like at the time of their presentation to our institute, we generally notice keratic precipitates away from the lesion. So usually these cases are indolent. They usually present to our institutes at a later stages only. And at that position, we can see the distribution of keratic precipitate beyond and have a sort of suspicion and tailor management accordingly.
So you noticed them at the time of first presentation.
Presentation.
So, what is the message you trying to convey to the general ophthalmologist?
Excuse me?
Do you trying to give any message to that general ophthalmologist?
Yes, if there is a case which looks like viral or fungal, and we are giving treatment for the same, however, it is not improving, and we notice that there are keratic precipitates distributed away, we can have a clinical suspicion that it may be microsporial stromal keratitis and conduct investigations accordingly, maybe do a corneal biopsy, and then give management.
If you have the facility, would it be prudent to also take a PCR in such cases to rule out HSV, VZV, or other viruses
Yes,
which
we can.
cause keratouveitis? So, agreed, microsporidia is there, but you'll also know whether there's a co-infection.
Yes.
Was it done in your cases?
In some cases, we also did, but based on these 5 cases, we found that based on histopathology as microbiology, it was microsporidia.
Okay, thank you.
Yeah, nice presentation, Dr. Ipsa. Did you check corneal sensation in all the cases?
Corneal sensation we checked. In some cases, it was, mostly it was not present.
Because the most common differential of this entity, I think
HSV.
it's herpes. So it's one of the very clinical, important clinical parameter that you need to do in all the patients. Right, thank you.
Thank you. Can we now have the next presenter, Dr. Soham?
Please put on Dr. Soham Basak's slides.
A very good morning, respected judges and dear colleagues.
Soham, just please wait. Please wait.
Is Dr. Anju here? Yeah. Can we proceed with our topic?
Good morning, everyone. Today I'm presenting an innovative technique of mini slit, a case series. Simple limbal epithelial transplantation is a surgical technique that restores the ocular surface in patients of limbal stem cell deficiency. But one of the very common issue with the classical technique is displacement of the limbal pieces. So how to overcome it? A sandwich technique was involved using this second AMG, which can be placed over the limbal pieces so that they are not dislocated. But the problem with this, that the second AMG is not cheap, especially with our clientele. So our surgeon, the surgeon who has done this innovative technique, thought of why not we place the limbal tissues directly over the raw cornea and then place the AMG so that they are not displaced and there is no increase in the price. This technique was used in 2 pediatric patients. Both were males involving the left eye because of the Lyme injury. The pre-op BCVA in first patient was 6/36 with astigmatism of minus 3.5 diopters at 70 degree, and second patient with the pre-op BCVA of 6/60 with the pre-op astigmatism of minus 4 diopters at 65. Both patients has partial limbal stem cell deficiency with no initial corneal surgery and wet surface, but the patient 1 also have an additional symboliferon. The initial step of harvesting the limbal tissue was same as the conventional slit technique, but on the recipient eye, initially the pannus was removed and then the limbal tissues were placed over the concerned area. This diagram is actually showing the whole cornea, but in these cases, the limbal tissues were placed over the concerned area, and then the AMG was placed. Since case 1 also had the symboliferon, so we have used the conjunctival autograft in that area. The results were pretty comparable to the conventional slit technique with good visual acuity at 9 months post-op. For discussion, it is a very common problem with the displacement of limbal tissue, especially in children, which is about 5 to 7%. So we can even thought of using a BCL, but the problem in pediatric patients is there is a high incidence of epithelial cell growth on the contact lens, plus they can even lose the BCL also. So to reposition these, the pediatric patient has to undergo another OT session because it cannot be done like in minor OT as adults. This study has proof that as AMG provides a conductive niche for progenitor cells to proliferate, the same can be provided by the corneal stromal surface. The AMG prevents the dislodgement of the limbal tissues. This modified is reported for the first time in India, especially, though the sample size is very low, but this requires future studies to validate. But the point is, this can be used as a breakthrough technique, especially when we have a poor clientele and we don't want the pediatric patient to undergo the second general anesthesia setup. Thank you.
Did you still put a bandage contact lens over the amniotic membrane graft?
No, ma'am, we haven't used BCL over these two patients. It was just the AMG.
I'm not very clear about the technique. When you put the limbal explants, did you put glue or you just put them and put the amniotic membrane on top of it?
Ma'am, sorry, I can't hear you.
Did you use glue to fix the
Yes, ma'am, we have used the glue for putting the limbal tissues, and over that we have put the AMG. Because what we have seen is even after the glue, because kids have a habit of rubbing their eyes or playing, there was very history of 5 to 6% chances of losing the limbal tissues. If not losing, at least there was displacement of the tissues. So this technique was helpful, especially for pediatric patients, not for the adults. This is good for pediatric only.
And have you compared maybe with the OCT the anatomical outcome between these?
Ma'am, actually these cases were done where actually I'm from an army setup. We didn't had the OCT to do the AS-OCT or any further investigations. It was basically on the slit lamp examination only.
And you've not noticed any morphological difference between the traditional technique?
No, ma'am.
Means you put the limbal pieces just
on the cornea with the glue,
and then you are putting one amniotic membrane. And what was the orientation of amniotic membrane? Epithelial side up or
epithelial
down?
Side up, ma'am.
Epithelial
Side up only.
Why did you say it's sandwich? Because there is only
no, ma'am,
one...
it is not sandwich, but a sandwich technique was tried in which first they put the AMG over the cornea, then the limbal pieces, and then another AMG. But that we cannot use in our clientele because AMG cost a lot. So using 2 AMGs, because our clientele is very poor. So that is why the surgeon thought of maybe using only 1 AMG.
But in your case, you are putting limbal stem cells on the raw
yes, ma'am, on the raw cornea
without any epithelium, and then you are putting amniotic membrane which has epithelial side up. So where is the scaffold for growing limbal stem cells? Because limbal stem cells are in touch with raw cornea and the stroma of the amniotic membrane. There is no epithelium to for the reepithelialization.
But that's what the suspicion is. Maybe the stromal surface of the cornea has acted as a niche for the progenitor cells to proliferate. That's what we want further studies to validate our suspicion. That's the suspicion of the surgeon, that maybe it's the stromal surface that acts as a niche rather than having a AMG.
Were any sutures used? Were any sutures used to
no, ma'am. No sutures were used. We have only used the glue. Even for the conjunctival autograft, the glue was only used.
Did you follow up the patients? What was the time for absorption of the amniotic membrane graft?
Ma'am, absorption actually, we have followed them till 9 months. It was not fully absorbed, but there was no any calcification also was not there because we were regularly following that monthly. Initially, they were followed weekly and then they were monthly till 9 months.
Okay, so there was no displacement of the amniotic membrane despite no BCL and no sutures.
No BCL was used, ma'am.
This technique has been reported, as you said, not in India, but...
ma'am, actually it's a published case.
Yes.
Yes, so
right.
I published it last year, ma'am, in AIOC. Thank you, ma'am.
Can we have Dr. Soham Basak now?
We'll just call out with just figure out if the other presenters are there. Dr. Rupa Epil, Dr. Rupa, Dr. Shankar Narayan, Dr. Pravleen Kochar, Dr. Vidya Bhushan Kumar, and the last talk is by Muhammad Rakib Tawhid. Okay. Yeah, please.
Yes, sorry about that. So I'll be presenting on the first 47 cases of DMEC and the transition from DSEC, no financial interest. So DMEC is now the standard of care for treating any endothelial pathologies. And it was introduced by Millies back in 2006 and has undergone a lot of changes. The current study aims to report the outcomes of the first 47 cases and look at the transitioning factors from DSEC. So 47 patients from September 2019 to July of 22 were taken. We looked at the visual acuity, cell density, and the complications, and compared with DSEC performed at the same point of time. Surgical technique, graft preparation by surgeon, and we are using an AR40 cartridge for the graft insertion, and inferior PI was done in all the cases. If you look at the demographics, 47 eyes of 45 patients were taken with at least 3 months of follow-up, more females. The average age of the patients was 61 plus minus 10 years. About 30% were triple procedures and the rest were DMEC alone. Indications, Fuchs alone was 21%, and then we have around another 20% of Fuchs in PBK in Fuchs. PBK due to other causes was 47%. Rest miscellaneous causes were TAS, HSV, eyes, and failed DSEC. The vision improved from logMAR of 1.57 to logMAR of 0.3 in the over a period of 2 years, and the cell loss reported at 2 years was 39%. This is one of the cases. An intraoperative complication, graft detachment, was noted in 15% of the eyes, and rebubbling was done in 3 cases. The others resolved spontaneously. There was no instance of graft loss during preparation. 1 pupillary block which required anterior chamber formation on day 3, and 2 instances of graft extrusion while injection, but they could be retrieved from the conjunctival cul-de-sac. Post-operative, 2 episodes of graft rejections which resolved with steroids hiking them up. No graft failure till the current follow-up of the study period. The pre-op CMEs which were detected were given simultaneous posterior subtenonous injection of tricort, and post-op CME was detected in 3 eyes. 2 were treated with the PST injection and 1 with NSAID. Post-op glaucoma was detected in 10% of the eyes. Now coming to the transition from DSEC, so this I've divided as per the years. So in the first year almost it was 50-50, but then due to pandemic, I decided to go to the more DSEC, which was more predictable in my hands. And again, from the last year, again, transitioned more towards the DMEC. And if you look at the indications, this is where the 3 places where it's highlighted. One is Fuchs, almost entirely shifted to DMEC. Then PBK in FECD, again, almost shifted entirely to DMEC. PBK due to other cases was about 50-50 distribution. And finally, in the failed PK and failed therapeutic, it was mostly DSEC was done. The triple procedures again was similar in both the groups, 30% for DMEC and 23% in the DSEC. So even though it's a beginner case, the visual outcomes were comparable to other experienced DMEC surgeons. The indications and endothelial cell loss matched with prior reported from our centers. However, the Fuchs was considerably higher compared to the reports from rest of the country. The graft detachment again matched those of other learning phase surgeons from India and abroad. However, there were few more missed follow-ups during the pandemic period. So tips for transitioning: the learning curve from DSEC to DMEC can be made smoother with lots of wet lab tissue practice and also case selection. However, the limitation of the study is the short follow-up period in some of the later cases. Thank you very much.
For the cases with pseudophakic bullous keratopathy, you preferred DSEC versus those with Fuchs and PBK. Am I right?
Yes. So the indication and surgery is slightly modified due to the pandemic, because in between those 2 years, there was a tissue crunch. So I was preferring more to do DSEC because of predictable outcomes. So those intervening 2 years, the results, all the surgical technique is more skewed towards DSEC.
Did you see more scarring in the cases with PBK and Fuchs, pre-existing Fuchs, compared to only PBK? Was there a difference in the clinical presentation? Because the scarring would hinder visualization of the graph.
Yes, ma'am. So the scarring seen similar actually. The Fuchs patients actually tended to present earlier because the decompensation sort of happens earlier and they come early. So we could intervene also earlier rather than only PBK cases.
So more of edema and less scarring.
Yes,
so your
ma'am.
visualization was better.
Yes, ma'am.
Thank you.
Thank you, ma'am.
What are the recommendation you give regarding the case selection part? Which cases would be favorable for the DMEC as the DC?
So as beginner, I would recommend all patients with a good anterior chamber anatomy, you can definitely go for DMAC. And if you have good visualization, so less of scarring, go for DMAC. But for post therapeutic PK and post failed optical PK grafts, then better to go for DSEC because the graft attachment is more predictable.
And Dr. Basak, have you evaluated the surgical time between how much time you were taking in the initial days versus the?
I actually had a slide, but for this I've reduced.
I think I missed that.
No, I have not presented it.
Okay, so what do you think? I'm sure the surgical time would have reduced. And do you think that has any impact on the?
Definitely. Initially, the surgical time would be around, for just without triple, would be around 40 minutes. So now that has come down to around 25 minutes.
So do you have a graph for that also, how your surgical time is improving?
I do not have it on this presentation.
I just want to know what new want to give the message to the what is the new things to what difficulties you overcome to.
So only two very important things to highlight is one is case selection. Go for the cases with good anterior chamber anatomy, and second is wet lab practice.
And
before starting.
This is your transition from
Yes.
DSEC to DMAC
Yes,
only.
yes, sir.
Nothing. Okay.
Thank you.
Can we have Dr. Rupa? Dr. Prablin Kochar?
Good morning. The topic of my presentation is outcomes after Descemet stripping automated endothelial keratoplasty in patients with Orolab aqueous drainage implant insertion. To begin with, there is increasing use of GDDs to control intraocular pressure in glaucoma patients, which has been attributed to their relatively good safety profile. Endothelial failure in patients with GDD occurs secondary to cornea tube touch, intermittent or persistently high IOP, and or surgically induced endothelial cell loss, especially after multiple procedures. Penetrating keratoplasty, as we all know, has been outweighed by DSEC as the most widely performed endothelial keratoplasty for endothelial diseases over the last decade, though DSEC is more challenging in such cases. So this was a retrospective case analysis done in a tertiary eye care center operated by a single surgeon on 4 cases. The minimum follow-up was of 6 months. We assessed the indications, medical and surgical treatment of glaucoma, IOP changes before and after surgery, post-operative visual outcomes and complications. Surgical technique, we use a Moria microkeratome for button preparation. Temporal tunnel, 5 mm was clear corneal tunnel was made. Desmetorexis was done using reverse Sinski. Tube shortening wherever required was done. The Trifine button was inserted into the anterior chamber by use of, it was glide-assisted sliding of the lenticule. Air bubble was injected and the wound was closed using Tenno nylon sutures. 100% air bubble was injected at the end of the surgery to achieve an effective tamponade. This is one of the post-op 3 months follow-up of one of our cases. So coming to the results, the patients were 4 patients were in the age group of 55 to 65 years of age. All had a prior RD in situ. One patient had TRAB followed by RD, and the other patient had TRAB followed by double consecutive RDs. The indication in all the 4 cases was different, being a PXF glaucoma, primary angle closure glaucoma, primary open angle glaucoma, traumatic glaucoma. The intraocular pressure was well under control in all the patients, with 2 requiring additional anti-glaucoma medications. The visual prognosis was good, with 1 patient achieving up to 6/9 vision post-operatively and 2 patients achieving 6/36. 1 patient did not improve because of primary graft failure. One of the cases we noted early graft dislocation on post-operative day 2, which was successfully managed by rebubbling. Coming to the discussion, the study shows that the DSEC is an effective procedure to restore visual function from endothelial failure in eyes with prior RD implantation. Post-operative breast-corrected visual acuity improved in all cases except one, which had primary graft failure. One of the patients had post-operative graft detachment, which required rebubbling, compared to other series which also required rebubbling in percentages from 26 to 39%. These findings are consistent with the frequently described phenomena of GDD predisposing to leakage of the flotation air bubble. So the air management in these cases is the most difficult because the air tends to escape from the GDD tube into the subconjunctival tube. And trimming of GDD tube within the anterior chamber to prevent contact with the graft may be necessary in some patients to achieve successful DSEC, and 2 of our patients needed this. Our study showed 1 DSEC failure, which is in line with the study by Kim P. et al. Eyes with multiple glaucoma filtration surgeries are more likely to have difficult to control glaucoma, which may increase the predisposition to DSEC graft failure, as seen in our case with primary graft failure. Also, in these cases, there is an altered anterior chamber environment. There's alterations in the proteomics. There is increased oxidation, apoptosis. So these patients are very difficult to manage. No IOP spikes were noted. To conclude, I would like to say DSEC in eyes with corneal edema secondary to endothelial dysfunction in the presence of a previous GDD is a successful procedure, though being technically more challenging. Thank you.
The eye which had the graft detachment, was that the one that failed subsequently?
No, ma'am. It was the trab with consecutive RD, which had graft detachment, but it survived. So the vision in that case was 6/36. The primary graft failure happened in the case with trab with consecutive RD implantation. So it was a pseudophakic eye. Like there were multiple surgeries, 4 surgeries done in that eye. So
How long would you wait after a tube to know that the eye is under control and you can safely go ahead and do a EK procedure?
ma'am, I didn't get you, ma'am.
How long would you wait after the valve implantation? How long would you wait before to take up the patient
To take up the patient
for a DSEC?
DSEC. Ma'am, as soon as these cases were all having corneal decompensation. So it usually happened after 3 to 4 years of implant. It was not like RD insertion.
Okay. And what was your post-op steroid regimen after
Steroids, we usually give 4 times. Antibiotic steroids, we usually give gatifloxacin and prednisolone 4 times per day for 15 days and then taper at monthly intervals. And these patients also, we started anti-glaucoma medications post-op for 1 month, and then if needed, the anti-glaucoma medications were continued, and then if not needed, they were stopped.
So all these glaucoma drainage devices were used, implanted using limbal route or somewhere from pars plana route?
Yes, sir, limbal route. All.
And did you compare the outcome of DSEC in these cases where implant has already been put in to the cases where no implants are there, means routine DSEC cases like endothelial cell counts and thickness, and what duration was there to get it clear?
Ma'am, in these cases, like all our DSEC, without the RD implantations also, whatever we've seen in our OPD is like 3 months. The best corrected visual acuity at 3 months will be, like initially it will take the graft to survive. So after 3 months only they'll have clear grafts and like good vision.
And what was the difference in the survival of both the types?
Definitely in non-glaucoma eyes, the survival rate is much more higher than compared to. This was the 4 cases that we studied were 2 years back. Now the surgeon is doing a lot of surgeries like DSEC in RD. So definitely the DSEC survival in non-glaucoma eyes is More.
And what is the longest follow-up in your case?
2 years, ma'am.
2 years.
Yes.
Thank you.
Thank you, ma'am.
Can we have Dr. Vidya Bhushan Kumar?
Is Dr. Raghib Tauhid here?
Good morning, ma'am. Shall I start? So my presentation is ocular anaphylaxis management and clinical outcome of after corneal bee sting. This is a case series report. Case 1, 4 years old female child referred to us with a complaint of swelling, increased lacrimation, pain, and not able to open her left eye for past 5 days. This episode occurs after swarm of bees attack on her all over the body, and as told by her parents. On gross examination, upper and lower eyelid bear mild edematous, conjunctival chemosis, and corneal edema was present on her left eye. Patient was not cooperative for the slit lamp and fundus examination, so we planned under general anesthesia for next day, and we did ultrasound B scan, which shows within normal limit, and ASOCT shows corneal edema with bullae. Intraoperative revealed that there is a foreign body, probably a bee stinger, embedded into the deep of the stroma of the cornea, temporarily at the 3 o'clock position and 2 mm from the limbus and her left eye, infiltration around the bee sting, and generalized corneal edema that may be due to the toxic and immunogenic response. After anterior chamber detail was hazy, but there was another foreign body was seen in which was stuck in the iris, and there was a heterochromia iris, pupil pharmacologically dilated, and lens was clear. Both foreign body were removed and sent for the histopathology and microbiological examination, which showed the bee stinger. Post-operative oral steroid was started, oral and topical, and with oral antihistaminic and topical antibiotic lubricating and cycloplegic eye drops. And topical steroid was started after 3 days of post-op. 1 week later, stromal edema resolved completely, although small opacity in the site of the bee sting remained. Child was able to open her eye comfortably. Vision improved to significantly to 6/36, and anterior chamber was quiet. Patient was registered for optical PK. Another case, 46-year-old male with history of honeybee attack on his right eye. Bee sting was removed immediately in OT, and medical management started. Post-op follow-up after 3 months, all the symptoms were subsided, but vision didn't improve significantly due to the corneal opacity, which was with corneal neovascularization and cataractous lens. Patient was planned for the optical PK, and thereafter phacoemulsification with PCIOL, and post-op BCVA was 6/6 part. Case 3 was also similar to the case 2. And case 4 was young male patient presented with the 3rd day of post-op sting injury with complete stromal lysis, melted cornea, perforation, planned directly for the therapeutic PTA, inflammatory member were removed, and lens over the lens, and was throughoutly started steroid, oral and topical from very next day of the surgery. Discussion: corneal bee sting have been rarely described in the literature that can lead to the potentially devastating complication like ocular anaphylaxis, which include keratitis, severe toxic endothelitis, bullous keratopathy, and corneal opacity, toxic uveitis, iris atrophy, and lenticular changes, secondary glaucoma, optic neuropathy, and even phthisis. So treatment usually aimed to minimizing the toxic and immunogenic response. However, due to the rarity of the injury, there is no established clinical guideline for the management of the patient. Yearly surgical intervention, which include removal of the bee sting and high dose of steroid along with the topical antibiotic, steroid and cycloplegic is the mainstay of the treatment. Take-home message is prompt and early intervention with removal of the bee sting. Oral steroid is must. Almost all patients need keratoplasty surgery due to severe inflammation and further corneal opacity. Thank you.
How did you do the anterior segment OCT under general anesthesia for the first patient?
No, that we did pre-operatively. The day patient was reported, that day we did ultrasound B scan and ASOCT, ma'am. But the patient, baby was 4 years old, so not cooperated for the slit lamp photo.
Okay. And what was the gap between the presentation and the keratoplasty? Did you do keratoplasty for all cases?
4 cases, ma'am. All cases we went for the keratoplasty only, and 1 case was a stromal lysis, complete stromal lysis within 3 days. Other cases after second case after 3 months because of the corneal neovascularization and lenticular changes.
I think these are very challenging situations, and I think very well managed. Very well managed because of the severity of the inflammation. These are very challenging situations, and a lot depends on how early the patient presents to you. So if the patient presents early, then the outcomes, we can try and help them out. But when they present late, like you showed the last case,
Yes.
present after 4 hours with a melt and you have to do a graft. So it's a very challenging situations, and I think you're right that very little available in the literature about how to manage these. So my question was about the therapeutic graft which you did. Did the how long follow up do you have, and did the graft survive? Because there is severe amount of inflammation. So I was just curious about how whether the graft. How long was the graft?
Among 4 cases, one case even regrafting was done because of the graft failure. So even after transplantation and proper management, chances of graft failure is rejection is very high.
Yes, agreed.
Did you use systemic steroids for any of the patients?
All the patients, yes ma'am.
All the patients?
Yes ma'am. Systemic.
Okay. Which systemic steroid and any particular dose?
One that mentioned 1 milligram by solon 1 milligram per kg body weight.
Okay, fine. Nice presentation. Thank
Thank
you.
you. Thank you.
Nice.
Just to confirm, is Dr. Rupa Epil here? Dr. Rupa? Dr. Shankar Narayana? Dr. Raghav Tauhid? Do we have any questions from the audience to any of the speakers? Yes.
I think this the bite has been done. Delayed case reporting has been there, and then the delayed treatment starting is very delayed, and so you see the extensive damage to the cornea. Otherwise, if the bee sting has been removed earlier, and you have given heavy doses of corticosteroids or steroids orally or locally, this drastic changes you won't be able to see. So in my opinion, these all have been delayed very much in all the things.
Dr. Bhushan Kumar, can you comment? Please.
Yes, sir, I agree with you. Actually, all 3 cases was presented late because we are working in the referral hospital at Regional Institute of Ophthalmology. So, patient is coming from the periphery. It will take 4 to 5 days, not very much delay. But 4th case was presented on 3rd day only with complete stomal lysis. So, presentation is very different. Some if a severe anaphylactic reaction is there, so within a week complete stomal lysis will be there, sir. So it's not like that all cases late presentation only we will get problem. Even within 2 to 3 days we will get complication like we have to go for the keratoplasty only. We don't have any other option.
In my opinion, it is just the reverse order. I have removed the sting and I have seen within 3-4 days the patient is getting all right. Yes, it means it is very much delayed. It is not even that 2nd or 3rd day. I am talking about these have been reported even after 7 days or 8 days. And then the treatment has been, initially you have started a very low dosage and then you have just see the advancement has not taken place, and then you have brought up all these things and drastic changes. In my opinion, each and everything has been delayed too much. In my opinion, this is the...
Yes. There are 2 school of thought also, sir. We have to remove as per literature, we have to remove the stinger as early as possible. Otherwise, we can leave the stinger there and so, and we can start the oral steroid and antihistaminic drugs, and that also giving the good results, sir.
No, you cannot, actually, basically, you cannot locate even the sting. Yes. Even in these changes, if delayed has been there, it is all hazy. You can't pinpoint the point where you have to remove it. Initially, you can see it seriously and you can remove it very quickly. and then the results are different. Then the results in the afterwards are different. But it is delayed. Each and everything has become, in your cases, each and everything have become hazy. And then you are, it is a blind eye. You are searching in a thing, actually, basically blind eye. You are searching for a thing, and then you are searching. So initially, surgically, you are also damaging more. And then I probably feel each and everything has been delayed. In my opinion, this is the
Point is taken, sir. Sometimes the patients, when they come late, there is nothing much that we can also do. But your point is taken that the later the patient comes, the edema is more. So locating the stringer becomes even more difficult. So thank you.
Yes, I agree, because early management always give rise to better outcome. But these patients are actually first managed by the emergency team in trauma or emergency sector, and then they after they manage the anaphylaxis, they send for eye consultation, and that's why these patients are coming late to us. And whenever they come, we always try to do some scraping first to rule out any fungal infection at the site of a stringer. And then we try to start a high dose or pulse steroid to, retrieve these cases. So that's the point where we start initiation of the treatment gets late.
Yeah, so it's time. I think we'll conclude the session here. Thank you, everybody.
One more question, please.
What is your protocol of management for bee sting injuries?
We can't hear you. Can you speak into the mic? Yeah.
Hello, can you hear me?
Yes.
What is your line of management for bee sting injuries? Because I have managed 2-3 cases, and in those cases, like I didn't use oral steroid. Like, are they absolutely necessary? And they just responded well with the removal of the bee sting and topical steroid. Like, do we need to give oral steroid in all cases? Because I didn't use and they responded well. So, what is your line of management?
Depends upon time.
It all depends upon the time of presentation, one, and second, it depends upon the severity. Sometimes patients comes with the systemic anaphylaxis, and those patients will require some aggressive treatment in terms of, even they require some tracheostomy also at that time. But in cases where the isolated ocular involvement is there, you can treat the patient with aggressive topical also. But I would suggest start topical as well as oral, because these cases give lot of toxin release, and they can cause endothelial dusting and endothelial decompensation. Along with that, there is lot of uveitis as well as lenticular changes. So to avoid all these ocular complications, we have to give aggressive steroid therapy in initial 4 or 5 days. Then you can taper the therapy to topical, and you can reduce the dose, and that will give rise to good results. And even then, after managing the cases very beautifully, you have to go for penetrating keratoplasty, or in some cases DSEC or other keratoplastic cases, because majority require that. All of them usually have endothelial decompensation in the last. Thank you.
Thank you everyone for your presence, and let's conclude the session.
Thank you all participants.